Morning. So we're going to talk about bone marrow imaging, and I think this is a very challenging topic. A few disclosures before we begin. So MRI is the mainstay technique for imaging the bone marrow, and there are a variety of sequences, of course, we can choose from to create the tumor protocol for assessing the marrow, and these are categorized as anatomic, functional, and metabolic sequences, and of these, the most important is the conventional T1 spin echo, or what nowadays we use fast spin echo imaging. I'm also going to be talking about fast, non-contrast techniques, the two techniques of chemical shift imaging and DWI that help us detect and characterize bone marrow signal abnormalities. So why T1 weighted imaging? So this sequence provides excellent contrast resolution between the marrow replacing well-defined tumor that's typically darker than skeletal muscle and the surrounding normal fatty marrow that's bright on T1 weighted imaging. And of course, this is an easy case, but unfortunately, we not only have fatty marrow, but we also have red marrow within our bone marrow, and there's normal marrow conversion chart that you see in front of you, where we're born with red marrow that converts to fatty marrow, first in the diaphysis, epiphysis, and then lastly in the metaphysis. And then when we have red marrow reconversion, which is common with patients who have obesity, smoking history, or anemia, then it happens in reverse, where we have increasing red marrow metaphysis in the metaphysis, diaphysis, lastly in the epiphysis. So we really should have fatty marrow in the epiphysis normally in the adults. So these are different age grouped patients. So the younger child, the adolescent, and the adult. And you can see the signal intensity of the red marrow is brighter than skeletal muscle. It's more ill-defined, and you see fatty marrow in the epiphysis that gradually converts to fatty marrow throughout the diaphysis there in the adult and a metaphysis. So in the axial skeleton, we often, in the adult, have residual red marrow, and this is ill-defined, brighter than skeletal muscle on T1 weighted imaging. And in the spine, if you don't have muscle to compare to, then you can use the adjacent disc, and red marrow is brighter than the adjacent disc. So what about this case? Is 7-month-old and then 11-month-old, and you see the marrow is really very dark, especially the 7-month-old, so it's not following our rules, but this is normal, and this is because we're born with red marrow. It's very dense. There's no fatty marrow yet, and it hasn't really converted. It needs at least a year to convert towards fatty marrow. And similarly, in the pelvis, you see the unossified hip cartilage, and then the rest of the marrow is so dark in the 7-month-old compared to the 6-year-old, where we see the more normal appearance of red marrow in the metadiaphysis and then fatty marrow in the epiphysis and parts of the diaphysis. Okay, so this is just a case to show how challenging. This is an adult. It's heterogeneous bone marrow. We see there's fatty marrow in parts, but there are also areas that are a little darker than the disc, perhaps, on the spine. But on the pelvis study, you see the signal intensity is actually brighter than skeletal muscle. But you see that the epiphysis, which should have fatty marrow by our pattern that we discussed, is completely filled with some sort of intermediate signal, and this is not a normal pattern. This is a patient with myeloma, and that's really the major clue. So here we have a 2-year-old, has a fracture, and we get this MRI, and the question is what's going on in this marrow? Could there be tumor here? Is it really dense red marrow for some reason? Could there be just marrow edema that's really extensive around this fracture? And to answer this question, we turn to this sequence, which is designed to exactly answer that question, to characterize this marrow signal. Is it normal, or could it be reactive bone marrow edema, or could it be marrow replacing tumor? So we'll talk about T1 weighted in-phase and a post-phase gradient echo, chemical shift imaging, very fast sequence. So it's based on the premise that protons attached to lipid and water precess with very similar yet slightly different frequencies. So if you have a voxel that contains both lipid and water, so that would be red marrow plus fatty marrow, or bone marrow edema plus fatty marrow, then you'd have a drop-in signal on the opposed phase compared with in-phase sequence. But if you have a voxel that only contains water, so that would be tumor, completely replacing all the fatty marrow, then you'd have no drop in signal on the opposed phase compared with in-phase sequence. So in the spine where you have this sort of ill-defined signal in the L2 vertebral body, is it reactive or could be a tumor? Well, you see clearly on the in and out of phase that it is a marrow-replacing lesion with no signal drop on the out of phase compared with in phase, whereas the other areas, other vertebral bodies show extensive signal drop on opposed phase compared with in phase because they're composed of red marrow interspersed with fatty marrow. So this was unsuspected metastatic breast cancer in a 40-year-old. So back to our 2-year-old fracture case. We see no drop in signal on the out of phase compared with in phase, so now we should be worried about marrow-replacing disease. And we don't just look at this visually. There is a quantitative metric. It's a little bit different between 1.5 and 3T, but 20% is a good number to remember. So less than 20% is positive, and over 20% is negative for marrow replacement and means that you're dealing with red marrow or reactive edema, for example. And usually if you have red marrow, it's much higher than this, like 50, 60+%. Okay, so here's a 7-year-old. Now you see the marrow signal. It's on the intermediate side, maybe similar to the disc level, but you look at the L5 body and some other vertebral bodies, and there's some loss of vertebral body height, so you should be suspicious that there are pathologic fractures here. But before you subject this patient to a bone marrow biopsy, then you want to be really sure as the radiologist. So I'm just reviewing another type of chemical shift imaging with the Dixon technique where you get in and out of phase as well as fat-only and water-only images. And when we look at the fat-only image here, you see there's no fat whatsoever. And so this is typical of marrow replacement, so we should be worried about leukemia, which is what this was. And you can, if you want, measure fat fractions, and less than 10% is consistent with malignancy in children, which something we studied relative to age-matched controls. You can do T1 or T2 weighted Dixon, and any of these techniques offer similar diagnostic utility for characterizing marrow signal abnormalities for marrow replacement. And the nice thing about chemical shift imaging is you can implement it in the whole body setting. And so on this fat-only image that you see, over here, you see there's no fat in the metadiaphysis of the femur, the epiphyses, the spine. So this is a patient with widespread marrow replacement or leukemia. Okay, so we'll talk about diffusion-weighted imaging now. So I think everyone's heard of DWI, so method of measuring the Brownian motion of water. So we take a T2 weighted sequence usually and make it diffusion sensitive. And expose the tissues to diffusion sensitizing gradients of increasing magnitude that are denoted by the B value. So a B800 image is more diffusion sensitive than B50. And then we're trying to look for how much signal loss there is on the B800 compared to B50 to tell us how restricted the motion, the Brownian motion is within that area of interest. And so if you plot the log signal intensity in your area of interest on each of these B values, the best fit line is drawn, and the slope of that line is the ADC value. So the ADC measures how restricted the diffusion is in that area of interest. So restricted diffusion means a small slope, low ADC value, unrestricted. Big slope, high ADC values, a lot of loss of signal on the late B value compared with early B value image. And this translates to our ability to separate out very cellular from less cellular areas, or basically malignant from benign lesions. So here we have axial views from the pelvis, FATSAT-T2, and our B50, B400, B800 images. And comparing our FATSAT-T2 and our high B value image, you can see this lesion denoted by the arrow has retained signal because there's a lack of restricted diffusion, and it's a site of metastatic disease. And I'll point to this other lesion in the right iliac bone that is even more conspicuous on the B800 compared with the FATSAT-T2 sequence. And DWI, similar to chemical shift imaging, is implementable in the whole body setting. So this is a patient with Leaf-Romani syndrome, osteosarcoma of the right hip, and we can use whole body MRI to detect metastatic disease. This is an inverted DWI high B value image, and you see there are lung metastases in this patient. So that's for detection. We talked about how we use DWI for detection, but of course we have ADCs, our quantitative metrics, so that helps us characterize these bone lesions. And malignancies tend to have lower ADC values than benign lesions, as expected. So here's our 2-year-old again with the fracture, and again, you see we decided with the chemical shift imaging, we're worried about marrow replacement. And now let's look at the DWI. So we're up by the hip now, the axial T1. The high B value image, we see there's a very high signal that's still present. And the ADC of 0.7, so less than 1, we are concerned about malignancy. So this tells us there's significantly restricted diffusion and worrisome for malignancy. Further down, you can compare the appearance of the bone marrow with the adjacent soft tissue mass in this patient around the fracture site. So could this be a malignant soft tissue mass or a hematoma? And you can see on the B800 versus B50 image, there's loss of signal on the soft tissue mass relative to the B50, but even more signal on the B800 compared with B50 in the bone marrow. And on the ADC map, you see restricted diffusion in the bone marrow, lack of restricted diffusion in the soft tissue mass. So now we can conclude we're dealing with a pathologic fracture with hematoma in this patient who has leukemia. Okay, so hopefully I've shown you how challenging I think it is to assess the bone marrow on MRI, especially in pediatric patients. So we have a How I Do It article that just got published. It's online. It focuses around whether you're dealing with a focal or diffuse marrow signal abnormality. And we have algorithms like this one for the focal signal abnormalities on bone marrow. You look at the pattern, the signal intensity. When you're not sure, you implement chemical shift and diffusion imaging. So here's an example on T1 where you have this focal abnormality in the sacrum. You see with chemical shift imaging, the lesion is a little bit smaller than you thought, but there's a lack of marrow drop in signal, and there is marrow replacement. And by diffusion, it retains its signal on the high B value relative to low B value with a low ADC. So this is a malignant lesion, a little bit smaller than you thought originally on the T1 weighted sequence because it's surrounded by areas of red marrow. And this is the algorithm for diffuse signal abnormality, which, like I said, it's all published online, so you can look it up later. And again, it starts with looking at the signal intensity and going from there into the patterns. And when you're not sure, you implement diffusion and chemical shift imaging and so on. And here's an example of a diffuse abnormality. Just again to highlight that there's this loss of normal fatty signal in the epiphysis, which is really should be a red flag for you. As a radiologist, this is diffuse metastatic disease. And again, the marrow here is very dark, darker than skeletal muscle, so that's another clue. And then here is one that's more subtle. So on T1, it's kind of iso to skeletal muscle. But with the chemical shift imaging, you see there's no drop on the outer phase compared with in phase, and this was diffuse myeloma. So that's, in summary, we talked about the importance of T1 weighted imaging. You start there, and then you can rely on these other fast non-contrast techniques to help you. And remember this article, which is online and has very useful